I've got a message in the chat saying everybody can hear me. Okay, great. So thanks very much to everyone for signing up for what is our first webinar for Venturi Cardiology. My name's Scott Murray and I'm one of the consultant cardiologists at Venturi, and I'll be joined tonight by my colleague Dr. Thomas Heseltine, who's another consultant cardiologist and co-founder of Venturi. And we'll also have the privilege of Dr. Denis Wat, who is a consultant respiratory physician in Liverpool, and he'll be talking to us about the effects of COVID on the lungs. So hopefully by the end of this session, you'll be able to ask some questions about what we've gone through. We'll hopefully be able to explain it to you in simple terms. And then at the end, we can tell you what we are able to do at Venturi to try and help people in the future with any symptoms that they may have with regard to their heart or their lungs. So without wasting any further time, I will share my screen and I will get the slides up. Can everybody see my screen here?
Yeah.
Chloe, I can still see you. Oh, you're gone. Okay. Great. Okay. So basically this talk is going to be, the first talk is going to be about COVID and your heart. And some of this might look quite detailed and technical, but I'll try to walk you through it as simply as possible. So we all know about COVID. It's been with us for almost 2 years now, and sadly it continues. So, you know, there was a lot of media around the fact that we'd reached 100,000 dead, but on the government website, we're currently at a state where we've still got 200 daily deaths, with about 1,200 deaths weekly, and we're up to a total of around 166,000, which is really a somber and sobering statistic. So what is COVID and how does it affect your heart? So this looks like quite a detailed diagram, but if you're able to follow my little pointer here, COVID is a virus and it enters the cell via a couple of different receptors, but the main one that we hear most about is this ACE2 receptor. Now, ACE stands for angiotensin converting enzyme, and to put that simply, it's a whole host of proteins that are made by the body that help control the vasculature or your blood vessels in essence. And they also control blood pressure, and they have immediate responsibilities in the heart and the kidneys. So unfortunately, the virus has a direct cytotoxic effect, and what that means is it can disturb and upset this receptor, but also, and more importantly, this endothelial cell damage occurs from the virus. Now, the endothelium is in essence the wallpaper that lines the inside of your blood vessels. So if you think of every single blood vessel in your body, each and every one of those has its own lining, its own wallpaper, and that's the endothelium. And the endothelium gets damaged by COVID. The other thing that happens is we get dysregulation of your immune system. So the immune system becomes hyperactive and it sends out a whole load of these messengers called cytokines, which can cause the immune system to really overreact to the situation and start attacking the body. Okay, so again, this looks quite complicated, but I'll walk you through it. So we've gone from COVID getting into the cell, and obviously the cells that line the blood vessels, there's a lot of that in the heart. So there's also endothelial cells inside the heart. So the virus can directly invade into the lungs and into the heart, but it tends to also upset the tiny blood vessels the microvessels, the ones you could only see under a microscope, and also the lining of the main coronary arteries as well. And what that does is causes dysfunction within these blood vessels and can lead to a heart attack, which is what we in the medical profession would call an acute coronary syndrome. In the same vein, it can also cause microemboli to go to the lungs, so small clots blocking the lung blood vessels and causing a problem there. This storm of inflammation and these various molecules that are activating the immune system can also cause damage to the muscle cells of the heart as well. And if the muscle cells get damaged and there's progression of that, then you can have two consequences. You can have heart failure due to a condition called myocarditis, or you can have a heart arrhythmia, so a problem with the electrical regulation of the heart, which is vitally important. Now, I'm not going to ask you what is on these slides, but it's just to show you that the virus can directly infect these endothelial cells, so these lining cells. And this image published in the Lancet shows viral inclusion bodies of COVID-19 in various sites in the heart, in the liver, in the guts, in the kidney. So it goes everywhere. It's a multi-system problem. So what we've just talked about there are insights into why the heart gets injured. And in studies both in life and on the bench, we see that the virus is directly toxic. It can create an immune-mediated response, so your own immune system attacking you. It irritates and inflames the lining of the blood vessels. It also causes small blood clots to form, which can lodge in the heart and the lungs. And it can also cause a supply and demand issue with the oxygen or the muscle fibers that is required to keep the system happy. I won't go into what Takotsubo is, but that's a different type of stress cardiomyopathy where the heart muscle is upset because of the stress of the illness. So all of these conditions here, which you don't need to know, but are basically subsequent downstream effects of COVID, can lead to heart muscle injury, and that then can lead to cardiomyopathy, which is a reduction in the muscle power. It can lead to a reduction in the muscle's ability to relax. It can lead to problems with the electrical system of the heart, so problems with electricity flowing in the right way, and that puts you at risk for sudden cardiac death, which is SCD. And there's also another arrhythmia which can be promoted by this, and it's called atrial fibrillation, so an irregular heartbeat that you may have heard of before. My slides are stuck. There we go. So to try and put this in context, because many of you may have suffered with COVID, but I'm not sure how many of you actually required hospitalization or severe care in intensive care. But if we split this down the middle here, we see that even if those who've had COVID infection, some lucky beggars are completely asymptomatic. And that doesn't necessarily mean that they won't go on to have future symptoms from this, but the likelihood that they will go into a recovery phase. If you had a mild bout of COVID that did not require hospitalization, then it is possible that you have symptoms of long COVID, which can be multifactorial, but can involve your heart and your lungs. And it's uncertain whether these symptoms will resolve with time and or treatment. I think we're still trying to understand what long COVID is. When someone has been in hospital or in ITU, then they're more at risk of developing this, what we'll call collateral damage or persistent structural damage, such as myocarditis, lung disease, heart failure, and arrhythmias. And obviously, if you've been in hospital, there's the risk of heart attack, stroke, or the delayed medical care from the pandemic. So what I'm trying to say in this slide is, if you've had a mild bout of COVID or you were asymptomatic, yes, you may have some latent symptoms, but you're much less likely to have some of the things that I'm discussing in this talk, such as serious heart problems, serious lung problems. However, if you have been in hospital with COVID, then that is a possibility. So I'm going to hand over to Tom Heseltine briefly for a few slides, because Tom is a specialist in heart imaging, and he's going to walk through some of these minor studies that we've seen since COVID came around about what we can find when we image the heart with echo and MRI. So Tom, if you're there, would you like to put your video and your sound on?
I'm here. Can you see
Hi,
me? I can just see you. No worries. I'll crack on anyway. Thanks, Scott. You see, as Scott said, my area of interest is imaging in the heart, and there's two main ways in which we image the heart in clinical medicine. The first and most common being ultrasound, which is an assessment of how the heart muscle and the heart valves are working. And the second, which is far more sensitive for looking at the heart muscle, is cardiac MRI. And that's the same machine that people typically have an MRI of their joints or their brain, for example. We use that in cardiology to image the heart, and it gives us very high resolution pictures of the heart muscle and allows us to study diseases of the heart muscle. What this slide shows on the left-hand side is that patients who develop COVID can get different types of damage to the heart. And you don't need to overly concentrate on the pretty pictures down on the right-hand side of the screen or left-hand side. But what this slide basically shows, it touches on what Scott mentioned in the MRI studies, is that a quarter of patients that were studied had evidence of myocarditis, which is an inflammation of the heart muscle detected on MRI. And about a fifth of the patients had evidence of a heart attack as the cause of the heart dysfunction on the MRI. The right-hand column relates to different ways in which a heart attack is caused, which is slightly outside of the heart, but is usually caused by hypoxia, which is a lack of oxygen from the lungs, which causes damage to the heart. So these are basically outlining the three main mechanisms by which the heart can sustain damage from COVID-19. The Venn diagram on the other side demonstrates the ranges of abnormalities that are found on the ultrasound test. Echocardiography is routinely performed in patients admitted with COVID-19 and is a widely utilized diagnostic test in cardiology. And I'm sure members of the audience have had an echocardiogram at some stage. But what this relates to is the different abnormalities that can happen. And that basically it shows that you have in about a quarter of patients abnormalities in the way that the heart moves. And again, in about less than a quarter, about 13%, there's the heart getting very stiff, which is common in inflammation. About a fifth of people have a global effect of the heart. And then the majority of patients, the right side of the heart, which is the side of the heart that pumps blood to the lungs, is damaged in the context of COVID-19. And that's thought to be related to the lungs being extremely inflamed with a obviously COVID-19 infection, and that puts strain on the right-hand side of the heart. Okay, next slide. Okay, this is a very interesting slide. And again, you don't need to focus on the pictures that are produced from the MRI images, but what this relates to is we have very sophisticated ways in measuring the level of fibrosis within heart muscle and the level of edema, which is swelling of the heart muscle. And this is a very nice study just demonstrating that patients with severe infection, which is the box plot on the far right-hand side of these graphs, that patients with hospitalised COVID-19 have higher levels of inflammation within the heart and have higher levels of fibrosis, which is scarring within the heart. And that's compared to healthy people, and also compared to patients that had mild bouts of COVID, so patients that were not hospitalised with COVID-19. You might see the risk factor matched controls, risk factors for developing severe infection. And I think we all know this are patients that tend to be overweight and have significant comorbidities such as diabetes, tend to be adversely affected by COVID. And the 70% abnormal T1 or T2, that just means that over 70% of the patients studied within this had abnormal levels of fibrosis or abnormal levels of swelling within the heart, which is really striking. What this means is that COVID-19 is a disease of the heart muscle as well as the lung tissue. So this, as Scott was said already, a multi-system disease. Next slide. And again, this slide is just, it's very busy, but we've just put this slide on just to demonstrate the range of abnormalities that you can expect in the heart in patients diagnosed with COVID-19. And these are, I think, about a dozen studies that have demonstrated abnormalities within the heart on cardiac MRI. And the incidence, so the number of patients, ranges between 7% to nearly 80% of all patients studied having abnormalities within the heart. So again, just backing up the fact that COVID-19 is a multi-system disease, not only affects the lung tissue, but also affects the heart in significant proportions. Okay, and this slide's just, I know it's very, again, very busy. This was just put up just to demonstrate in terms of imaging and taking blood tests, how we can diagnose problems with the heart and COVID-19. And it ranges from taking blood cells to look at the levels of inflammation and the levels of, the levels of inflammation and the levels of enzyme that is released when there's heart muscle damage. So there's various ways in which we can test that on blood tests and ultrasound images and cardiac MRI. And I think this quote's been put up, and I think we talked about it just before the meeting, but really poignant. At first, there is a small injury to the heart muscle, which is likely to occur damage at the acute stage, so the beginning of COVID, which triggers a slow evolution of diffuse muscular inflammation. So that basically means you have a sudden small injury to the heart muscle at the beginning of the COVID-19 infection, and then over time, you develop an inflammation of all the heart muscle. And that doesn't necessarily happen over the first few days or even the first few weeks, but can be a protracted process. Okay. Is there anything more you wanted to say on that, Scott? Or
No, that's great. Thanks, Tom. Thanks so much. So we move on just to discuss long COVID. Now, long COVID has become a term that's used all the time, but it's actually a term created by a patient who was an archaeologist who in May 2020 went onto Twitter and created the hashtag long COVID to try and describe the symptoms she was having and the constellation of swinging symptoms that she'd had up to 3 months after the acute infection. And we suspect that there is multi-organ involvement here with long COVID, and it is allowing patients to help define the long-lasting symptoms of COVID. And if you see here on this side of the screen that there are more than 200 symptoms reported post-COVID-19, and this is a study of 56 countries with more than 3,500 respondents. And the main symptoms at 6 months are fatigue, post-exertional fatigue and malaise, some mild cognitive dysfunction, and there are 10 cardiac symptoms that feature that are arrowed here. So I've just made this a bit bigger so that we can see. So breathing difficulties despite a normal saturation level, tightness of the chest, shortness of breath, pain and burning in the chest, dizziness, balance issues, fainting, fatigue, tachycardia, fast heartbeats, heart palpitations, lower esophagus burning in the gullet or reflux, and post-exertional malaise. But you can see that that's 10 out of 200 other symptoms that are part of the complexity of long COVID. There have been follow-up studies now published in the Lancet showing that 6-month consequences of COVID-19 in patients discharged from hospital. 1,700 patients have fatigue, 60% sleep difficulties in a quarter, a residual abnormal chest CT in half, abnormal lung dynamics and lung oxygen transfer that Denis will go into in up to a half. And this is more in with increasing age, female sex. And using other therapies were not associated with ongoing symptoms. But you see here, the main thing is fatigue or muscle weakness. So some people who've come to Venturi so far with symptoms tend to mention that their heart feels like it's beating more rapidly or irregularly, and we call that palpitations. Some people are feeling lightheaded or dizzy, especially upon standing, and some people have got persistent chest discomfort. Now, we've also seen quite a few patients who have this syndrome that's called postural orthostatic tachycardia syndrome, where when you get up from a lying or a sitting position and you start to move, you feel like your heart is racing and you feel like you might collapse. This can also lead to fatigue and lightheadedness and really a general loss of your independence and confidence. So in terms of what we can do in Venturi, we can investigate residual symptoms. So symptoms such as chest pain or discomfort in the chest, palpitations or feeling of extra beats, shortness of breath on exertion. Dysfunctional breathing is something we're seeing a lot with people subconsciously hyperventilating because of the illness that they've suffered or the stress and anxiety of the pandemic or having to wear masks. We see people with shortness of breath when they're stooping or bending. There's a residual amount of exercise-related symptoms that people are coming with, and also feeling like they may collapse or feeling weak. And obviously, given everything that everyone's been through, there is a lot of health anxiety around, as you can imagine. But our main sort of phrase here is that in order to tackle any of these symptoms that we have above, that starts with the fresh knowledge from a history examination and a detailed investigation to prove that there is nothing sinister or untoward underlying those symptoms. There's nothing worse than being in the dark about your health and not knowing what is going on and being worried. And the anxiety that comes with that can play a role in how someone's feeling. So we are trying to shine some sort of light on the darkness that people feel when they have residual symptoms. For instance, this is a 45-year-old teacher from Liverpool who told a story of 2 months after first being diagnosed with COVID, she found her heart was racing without warning, going up to 190 beats a minute. Could be in the middle of the night or during the day, and she would feel like she was going white as a sheet and begin shaking and have to grab on for support. Now, in order to sort out whether this is a residual real problem, we need to investigate for palpitations. Now, that could be anything from ectopic beats, which are often benign, to this postural orthostatic tachycardia syndrome, to an irregular heartbeat or a really fast heartbeat. But sometimes deconditioning and anxiety also play a role in the body generating palpitations. So from a Venturi perspective, we've gone through the stuff on the right here, that there are multiple things that can occur related to COVID-19. And what we can fight back with is the ability to evaluate residual symptoms. And the first thing that is required is a good history, and that takes time to do. Often time that your GP or in some cases, a cardiologist or respiratory physician in an NHS clinic just doesn't have time to do. A good examination, a face-to-face experience where you can be examined instead of being spoken to over the phone. An ECG to look to make sure that that's normal and not abnormal. And if there are symptoms of palpitations, then a 24-hour tape or a 5-day heart tape to see what is actually going on when the person is in their normal daily life. We can provide an echocardiogram, which, as you've seen, is an ultrasound of the heart to look for specific abnormalities. We can walk people on a treadmill to try and provoke symptoms and to check that their heart is working appropriately and is not racing or struggling for blood. We have an on-site CT scanner, which allows us to get detailed images of the heart arteries, the heart structure, and also of the lungs. We can refer on. We have two specialists Tom and Jonathan are specialists in cardiac MRI, and I would describe that as being the 4K TV gold standard heart image, with echocardiogram being a bit more like a black and white TV image of the heart. So we're able to do that. And obviously we have the ability to send to our local lab, the doctor's lab in Manchester, any specialised blood test that might be required after the history and examination. And we can give those answers on the day or within days, and at most for things like cardiac MRI or other advanced tests that need to be referred into local hospitals, then that can take weeks rather than months. So I'm going to end my talk with a good news story. So very recently, October the 7th, 2021, the Irish Cardiac Society presented findings of the Setanta study, which is the largest Irish prospective study on long COVID and heart health. And what they found was that of those with new onset cardiac symptoms, 62% reported shortness of breath, 54 had palpitations, and 53 dizziness, and 41% had chest pain. And although a high proportion of the patients who participated in the study presented with residual symptoms, the authors say the good news is that the initial findings provide reassurance that there is a low prevalence of lasting cardiac damage. So many infected patients can experience residual symptoms. So 1 in 10 patients showed some evidence of fluid collection around the heart, but less than 3% showed evidence of significant scarring when their hearts were tested. So I think that's a reasonably good story to end on, that you know, we've explored that if you've had a mild bout of COVID and you have residual symptoms, then it's good to have them investigated for peace of mind, but there's a likelihood that less than 3% have significant heart scarring. So a few pictures of the clinic that we've managed to set up in Warrington. And what I will do is hand over to my colleague, Dr. Denis Wat, who's a respiratory physician at Venturi, and he's going to do a talk about the lung complications of COVID, and then we'll take your questions at the end and trying to get you some answers. So thanks very much for your attention. Denis.
Okay, thank you, Scott. Scott, I need you to stop sharing. Yeah, thank you. Let me see what I can do about sharing my screen. I am just going to talk about the long-term effects of COVID on the lungs. Okay, so what I'm going to cover today, some of it is already been covered by Dr. Murray and Dr. Heseltine already. But what we'll discuss tonight is about the background of COVID-19. What is long COVID, which I think Dr. Murray has already described very nicely already, but I'll just cover it once again. What investigations are required for patients with persistent chest symptoms following COVID-19 infection? What treatments are available? And what do we actually offer here in Venturi for patients who have got ongoing chest symptoms following COVID pneumonia? So COVID-19, we all know very well, but it actually is an abbreviation, or it's a short for coronavirus disease 2019. It's a disease that can not just affect the airways, but it can also affect the lungs. And typically, the chest symptoms that we see in these patients are very much similar to those patients who's caught a cold. So they can present with breathlessness, a persistent cough, fever, and a lot of patients actually say they lost their sense of smell and taste. So what category of patient would be at risk of catching COVID-19 and subsequently affecting the lungs? So usually we tend to see patients who have got underlying lung conditions, such as those patients with asthma, COPD, or maybe some patient who may have got lung fibrosis. Unfortunately, age is also a massive risk factor of catching COVID-19 infection, leading to pneumonia. Also in those patients with impaired immune system. And for those people who smoke cigarettes, they are 5 times more likely to get COVID-19 pneumonia than people who don't. And at this stage, once again, I probably won't be the first one, but I'm sure you heard many times that smoking cessation is vitally important, whether it's for COVID or for other health reasons. So how can we reduce the risk of catching COVID-19? The top two, I'm sure we all know very well about these, following government guidance, try to work at home, try not to go to crowded areas. If you do meet with loads of people, go to places which are well ventilated. The other thing we know very well, and many of us probably has already done so, is to get vaccinated. Because being fully vaccinated means we are 3 times less likely to catch coronavirus. It is also encouraged that we should take the COVID-19 test. Typically would be the lateral flow test. Many local chemists actually do provide the lateral flows. It's actually also good to do it, even if we are asymptomatic, because about 1/3 of the healthy individuals actually carry the virus without them knowing they've actually got the infection. Washing the hands regularly, wearing a face mask, if all possible, these are all very simple measures. So is it actually necessary to have post-COVID assessments? Well, Dr. Murray already mentioned before that actually the number of patients who get long-term consequences for following COVID infection is actually quite small. But as a peace of mind, and also some patients do have some residual chest symptoms, I do feel that it is highly warranted that they should get a thorough respiratory investigations. As mentioned before, most people do make a full recovery within 12 weeks, but unfortunately, some people don't. The chance of long COVID is actually not linked to the initial severity of illness. We have seen chest patients who ended up being the intensive care unit, being on a supporting machine, but yet again, they actually recovered very well. We've also seen patients who had very minor symptoms and was managed at home. They have long-standing symptoms, and some of them have symptoms ongoing for more than 12 months. If you do have those symptoms, I think it is important to consult your GP if possible. But I think we already touched upon that it is difficult to get GP appointments. That's number one. Secondly, is GP are busy, they're catching up with COVID. I don't think they will have time to go through the patient's symptoms thoroughly and organize the appropriate test to work out exactly what's going on with the breathing issue that the patient is suffering from. So therefore, anyone who has got persistent chest symptoms, which to my mind lasting more than 3 months or 12 weeks, if they're worried, I think they will warrant a thorough respiratory review. I won't go into what's the definition of long COVID. I'm sure we all know. In short, basically, patients have persistent symptoms that last for more than 12 weeks. It's been shown that actually 1 in 7 people tested positive for COVID end up going on to develop long COVID syndrome. And from the UK National Statistics Office, it's been shown that 1.2 million people in the UK have got long COVID. I'm going to jump some of the slides because I think some of these has been discussed already. So the symptom of long COVID, my slide is not as comprehensive as the one that Dr. Murray showed us, but I highlighted a few areas which are common symptoms that patients with long COVID tend to experience. And certainly these are the symptoms that I tend to see in my chest clinic. Typically would be breathlessness on exertion. Sometimes they also mention about being breathless, even sitting at rest. We talk about this disordered breathing pattern, which is a very abnormal breathing pattern when they're breathing. Now, it could be related to damage to the lungs, but sometimes it could be because of additional stress the individual has gone through over the last 12 to 18 months, leading to the breathing pattern being abnormal. So some people call it air hunger. They try to fight for their breath, but in fact, it's the pattern of breathing is not right, therefore making the patient feel breathless. Sometimes patients also complain about difficulty with sleeping. Some people also mentioned that the memory and concentration not as good. We sometimes call it brain fog. We also see some patients get palpitations. I won't go into the details. I'm not an expert. Dr. Murray, Dr. Heseltine are the two experts talk about the palpitations in the heart, which we did discuss about 20 minutes ago. These are the common long COVID respiratory complaints that I tend to see. So many patients now have got their own what we call oxygen saturation monitor, may it be a smartwatch or a pulse oximeter. So some of them actually measure them quite religiously at home and notice that the oxygen level are either being low at rest or sometimes being low when they start walking around or doing some housework. A lot of patients will tell me that they get breathless, as I mentioned, sometimes at rest, but most commonly when they're doing something. They find it difficult to carry out their daily activities. Some patients also complain of wheeziness, chest tightness. And interestingly, there is a cohort of patients that tell me that their voice has changed. Now, it could be related to because they've been coughing a lot. And also, unfortunately, some patients who end up in the intensive care units, they have the ventilator, a tube that goes through the mouth, through the voice box to support the lungs, that may have also caused some damage to the voice box. Hence, the voice never quite recovered. And the voice box is not just important in terms of making sound, help us to cough, but the voice box also allows us to actually open and closing, allow us to breathe. When the voice box movement become disordered or discoordinated, that's when patient also exhibits symptoms of being breathless. So needless for me to say, COVID pneumonia can cause lung injury. As I mentioned before, most patients do recover well, but some patients went on to develop permanent lung scarring. The degree of lung scarring actually corresponds to roughly how much oxygen that they need. And there's a study here that showed that about 30% of the patients get what we call lung injuries. And the technical term we use is actually pulmonary fibrosis at about 12 months after the initial COVID infection. And up to about 40% of patients have what we call abnormal spirometry. This is that blowing test that some of you may have done it before, up to about 4 weeks after COVID infection. In other words, COVID infection can almost certainly, in many patients, causing lung damage. We talked about blood clots before. I'm sure many of you heard about it. We actually call it pulmonary embolism. So approximately about 10% of patients can get pulmonary embolism in the acute phase when they're not well. Some people end up getting it a little bit further down the road. It may be related to the fact that having been unwell for several weeks and months, their mobility reduces. When the mobility reduces, the blood flow is not as efficient. Therefore, the blood starts sticking together, causing blood clots. Blood clot can cause mortality and also can cause back pressure to the heart and also leading to further damage to the lungs and the heart. And that's the reason why in patients who present with breathlessness, from our point of view, it is important to exclude blood clots being one of the culprits. Airway inflammation. So before COVID has taken center stage, I'm sure many of you have had cough and cold before. Some people will say that they get breathlessness, chest tightness, wheeziness for weeks after a cold. It's almost similar to patients got asthma. And I don't think there's any predictors as to who will get it, because basically it affects three groups of patients. It affects patients never asthma, no risk of asthma, in other words, no allergies, no family history of asthma. They get COVID, they can develop asthma symptoms. It also obviously will affect patients with underlying lung diseases, especially the asthmatics. We briefly talked about this breathing pattern disorder. There can be many triggers, as you can see in that little diagram on the right-hand side. It could be related to the patient posture. It could be related to musculoskeletal issues. It could be related to the breathing pattern, gastroesophageal reflux, sinus issue, hormonal change, or medicines. But for whatever reason, it seems as though a high proportion of patients who had COVID-19 infection go on to develop this disordered breathing pattern. It's quite abnormal. And when the breathing pattern is not in a regular fashion, that's when patients actually complain of being breathless. But from my point of view, before we label somebody's got breathing pattern disorder, I think it is important for them to undergo thorough cardiac and also respiratory investigation, because from my point of view, very likely this diagnosis is made through excluding everything else. So what are the appropriate post-COVID respiratory assessments? It tends to be very comprehensive. I think also need to be holistic. Dr. Murray already mentioned that it requires a thorough clinical assessment by experts, not just 5 minutes. It may need 10, 15, 20 minutes, quite a long time to go through the patient's current history, their pathway history, what medication have they been taking, and also a thorough examination to work out what's going on. From then on, the patient may need various investigations as listed below. I'll go through them one by one. Pulmonary function tests, sometimes we call it spirometry. Some of you may have done this before, where we ask patients to blow out into a machine to measure the volume of the lungs. As I mentioned, about 30% of the patient with long COVID pneumonia can develop pulmonary fibrosis, and typically the lung get restricted, and that can be reflected by this blowing test. They also may need some sort of in-depth imaging, which Venturi does offer, which is a CT scan of the lungs. It gives us many information as to how much damage of the lungs has been caused by COVID itself. Secondly, it also tells us other information that the CT scan may provide, such as maybe sputum retention, underlying inflammation of the lungs, the distribution of scarring. And I can give you one example. If somebody who's got a lot of phlegm being stuck in the lungs, which is at the bottom right, when we come to managing the patient, especially what we call chest clearance technique or chest physios, this may be the area we should concentrate on. Whereas if somebody who's got more damage on the left, maybe this is the area where the chest physio should spend more time on, as this may help to actually bring up as much sputum as possible from the patients. A walking test, which we briefly talked about. From my point of view, walking test has got many values. Number one, it tells me approximately the fitness level of the patient. Secondly, also tell me during the walking test that this patient actually dropped their oxygen level. And also you can imagine if we do this test periodically, every 6 months, every 12 months, we can actually see whether things are actually getting better or actually getting worse in terms of the distance the patient can cover within 6 minutes, and also the degree of oxygen level changing during the 6-minute walk. Sputum sample. It is well known that viral infection can cause what we call secondary bacterial infections. I think we said it for many years that don't give patient antibiotics if they've got a cold, and also mentioned that COVID does cause a cold. However, we also know that COVID can cause bacterial infections, and that's the reason why when patients get admitted to hospital with COVID pneumonia, they will get antibiotics, because of the damage caused by virus that allow other infections or organisms to invade the lungs. So therefore, getting a sputum sample from patient is important, because it will guide us to initiate the appropriate antibiotics to the patient. So hopefully the patient can recover quicker. Some patient, unfortunately, has got significant lung damage. They've got low oxygen level. They may benefit with oxygen assessments. And to get the patient better is not just about giving more medications, working out what's wrong with the lungs, but it is also important to improve the general fitness of the patients. I think we mentioned that COVID is not just a cardiac or lung problem. It can actually be a multi-system disease. Therefore, a patient can lose muscle strength, lose muscle mass, lose their overall fitness level. And that's the reason why prescribing exercises is extremely important to get the patient back on track, particularly after they have been suffering from long COVID syndrome. So in terms of management wise, there are many things in patients who may have got asthma symptoms, inhalers, patients who get recurrent infections because lung get damaged, therefore they become more prone to get opportunistic infection. Maybe the use of long-term antibiotics can break the cycle of recurrent infections. Oral steroids are very good anti-inflammatory medications. So after the lungs has been infected by organism getting inflamed, steroid can help to improve them. I already mentioned that sputum clearance is important because some patients may retain quite a lot of thick, sticky sputum. Just coughing itself may not be able to bring everything up. And the longer the sputum stays in the lungs, the more likely these will become like chewing gum, sticking to all kinds of organisms. And that's when the patients start getting recurrent infections. But unfortunately, when they get more infections, the lungs become more damaged. When the lungs become more damaged, there's more phlegm. When there's more phlegm, more infection. You can imagine the vicious cycle itself. I mentioned about oxygen therapy, especially for patients who have got low oxygen level. It is also important to address the anxiety level these patients may be suffering from, in part because they're not able to do things they were able to do before. They always feel that they're playing catch up, and also maybe they've gone through a very tough period just to try to get over the acute phase of COVID pneumonia infection. It is also important to assess one's breathing pattern, as some patients may develop disordered breathing pattern. I also mentioned about exercises in the form of pulmonary rehabilitation. And of course, there are clinical trials where a patient may join to see if any new treatment can actually help them recover better. So what do we offer in Venturi then? We mentioned that we can send patients for specialist blood tests to work out what are the reasons as to why they're breathless. We offer lung function tests to measure the volume of lungs. It may give us an idea as to how much damage the COVID-19 has caused one's lung disease. A CT scan, which we've got a CT scanner on site in the clinic, that will give us detailed evaluation about the structure of the lungs. We also provide a thorough clinical assessment and also examination by respiratory experts. And if appropriate, we'll provide patients with the correct medications. Hopefully that will get them back on track. And more importantly, we do prescribe exercises to patients. Hopefully this will improve their overall fitness and enable them to recover from this very debilitating illness. I'm going to stop here and I'll let Dr. Murray take over from here.
Okay, thanks very much, Dennis.
Let me stop sharing my screen if I can. Have I stopped sharing, or am I still sharing?
That's all right, I've done it for you.
All right, thanks, Scott.
That was brilliant, Dennis. Thanks very much. That was a real tour de force of what to expect for a respiratory consultation with COVID. So I think we should probably open it up to the audience. They've probably been bored to tears long enough hearing about COVID and have probably got disordered breathing patterns, anxiety, all sorts of things happening now. So there are a few questions in the chat box. And if I go to the top, I think there was one there that I can answer, which was about if the vaccine is known to affect the heart and lungs, and if COVID does affect the heart and the lungs for long COVID, what specific treatments are there? So I think we've answered some of that. To answer some of the vaccine queries, yes, unfortunately, the vaccine can cause myocarditis. But when we look at the studies around the weighing up the difference between the vaccine and COVID-19 infection, some studies have shown that up to 500 people per million will get myocarditis with COVID-19 infection. But when they are given a vaccine, the risk of developing myocarditis with a vaccine is something like 50 per million. So somewhere, it depends on the age group. There is an increased risk in young males for getting myocarditis, but you see the difference there. You're more likely to get myocarditis from COVID-19 infection and obviously more severe symptoms if you're unvaccinated compared to if you're vaccinated, and the vaccine risk is lower than getting COVID-19. So it doesn't answer the question of what happens if you get vaccinated and then you get COVID-19, which is still a possibility, as you know. So yeah, there's another question here, Tom. You might want to answer this one. This is about how does COVID cause myocarditis? I think we've said much about that in the talk, but this is someone who was admitted to hospital, had high troponin levels in the blood, and was discharged, but hasn't been able to speak to a cardiologist about the residual symptoms. So I think, Tom, do you want to say anything about that?
Oh, yeah. I mean, it's complex is the honest answer, and not fully understood, but it's thought to be sort of direct viral infiltration into the myocytes, which is the heart muscle cells, and that causes inflammation, and that inflammation perpetuates damage to the other heart muscle cells. So it's not necessarily, there's an effect from the virus itself causing dysfunction, causing the cells not to work properly. And then from there, there's then the inflammation which follows, which affects the other heart muscle cells around it, which causes the heart to not work appropriately. And what we find is that over the period of time, well, in the initial phases, that inflammation we see particularly on cardiac MRI as a fluid in the heart. And then over the longer term, as the inflammation settles down, you get left with scarring within the heart, which we pick up on the MRI scan as well. So there's two main mechanisms. It's firstly the viral related thing, and then it's a subsequent inflammation generated from that causes the heart muscle dysfunction.
Okay, I mean, if anyone on this chat is not getting answers from the general practitioner or from hospital treatment, then we do have and you're not within our locality, we do have the ability to do virtual consultations, so video consultations online. Denis, there's one here from a relatively young person who said, I've got an immune system problem due to juvenile idiopathic arthritis. A year ago, I was on a respirator with COVID pneumonia, which destroyed my lungs, and I had a stroke and myocarditis. And now a year later, just simply walking up the road makes me pass out due to heart feeling is beating in my ears and my lungs are getting tight. My GP won't refer me to hospital as they're still not seeing anyone. I don't know where this person's based, but I think it sounds to me very much like you really need to have some further investigation and perhaps correspond with us offline, and we can get you details and sort something out. Denis, is there anything you want to say about people who've been in ITU and on ventilators? You may have seen more of that than I have in terms of having to deal with respiratory complications of COVID.
What we have seen is that those patients who end up being on a ventilator, they are more likely to have lung damage or long-standing lung damage compared to patients without being on a ventilator. Now, this has got nothing to do with the ventilation itself. It's just the natural history of the illness and the infection. Also, one thing I'm not quite clear as to when this individual was on the ventilator, because we all know that the management of COVID-19 pneumonia has changed quite significantly, even over a short space of time, about 12 months, 18 months, from no antibiotics to antibiotics, from no steroids to steroids, to no antiviral to antiviral. But one thing we do know that if anybody were to develop COVID pneumonia, ending up being on a ventilator, they'll almost blanketly get a combination of antibiotics, steroids, antiviral, with the hope that this will speed up the recovery. But we do, from my clinic, what I've seen is, despite some patients have received the full works, it's just unfortunate that they are left with long-standing lung damage. And as Scott said before, it sounds as though this individual will benefit with thorough cardiac and respiratory investigations to work out what has been going on through the consequences of COVID-19 infection.
That's great, Denis, thanks. I mean, if that person gets in touch with Chloe, who organised this event, at hello@Venturi Cardiology, then we'll talk to you offline in the coming days to try and get you a solution. There's another question here. Can COVID-19 cause demyelination of the nerves in the brain? Yes, I think it can. I think what happens is, I've obviously showed you that COVID can directly infect the endothelial cells of lining the blood vessels and cause an inflammatory problem there. I think it can also directly infect the myelin sheath of nerves and set up a similar reaction there. Now, I'm not a neurologist, this is probably a question for a neurologist, but I think that there is evidence of that, but there's not a lot of published literature confirming that. So it's maybe not one for a cardiology and respiratory talk, but Denis, do you know anything about that at all?
I haven't seen demyelination affected the brain, although I have seen someone who had demyelination affecting the breathing muscles following COVID, and ended up in the intensive care units. And strangely enough, is the lungs were not affected, but it was a muscle, it's a nerve supply to the muscle that got affected. Therefore, led to weakening of the respiratory muscle, leading the patient developing respiratory failure. But over time, fortunately, the patient did get better. But I have not seen demyelination in the brain. Similarly, I'm not a neurologist, so I really can't comment.
Is that a bit like a Guillain-Barré type thing?
Absolutely.
Yeah, okay. Well, I don't know whether there's any other questions or anybody wants to have anything answered, but we're at 8:30 now, which was our agreed time limit. I'm sure you've all got other things you want to be doing rather than listen to us drone on about cardiology and respiratory and Venturi. So I'd like to thank everyone for joining tonight. I'd like to thank Denis Wat, consultant respiratory physician, for giving us an excellent talk. I'd like to thank Chloe, a PR and marketing manager, for setting this webinar up, and also my colleague and co-founder Tom Heseltine for chipping in with his expertise. So thanks so much for your time, and get in touch if you need to get in touch with us. We'll be happy to see you at any point, be it virtually or in the clinic face-to-face. So good luck and take care. Bye.